Good morning, everybody. It's my pleasure to start this early session, and I have to thank Invivoscribe for inviting me to share our data with you on the use of the LymphoTrack assay in the clonality assessment and MRD analysis in acute lymphoblastic leukemia and myeloma. So I'm working in the clinical hospital of the University Hospital Brussels, and in the clinical lab, and we are in fact the central lab that does the MRD analysis for all children in Belgium with acute lymphoblastic leukemia, and we also are involved in myeloma studies. So first about the minimal residual disease. So we all know that in childhood ALL, MRD is a strong independent prognostic marker, and it started already to be implemented in standard of care treatment protocols since the early 90s. And the testing for MRD, the golden standard is still the immunoglobulin T-cell receptor, ASO-PCR, and that has been implemented all over Europe and beyond via the EuroMRD network that has defined guidelines for interpreting these testing, and it's very well standardized. I wanted to see if we could use NGS to improve this assay. In myeloma, we all know that MRD is also a prognostic marker, but it lasted a little bit longer before one started to get interested in that. Only since the 2010s, there were clinical trials that showed that there could be MRD negativity applied when you apply a modern 3-drug combination therapy. So hopefully for myeloma also, MRD will be introduced in the clinical decision making for these patients in the future. For myeloma, the MRD testing in these clinical trials were done by next generation flow or NGS, but this is not implemented and standardized in many countries, so we wanted to see if we could apply this technique in our lab. So first, I will show you the results of the molecular target identification via NGS, via the LymphoTrack, and we compared this with our regular fragment analysis, the capillary electrophoresis and Sanger sequencing. And then I will show you some results about MRD testing using these NGS assays, and we compare this with the ASO-PCR, and I will tell you something about the calibrators we have used and about sensitivity issues. So first, the targets for these assays. These are the immunoglobulin and the T-cell receptor targets, because they have junctional regions that are very variable. They're very unique for every B and T cell because of the joining of V, D, and G germline segments, and then you get the N insertions. Bases are inserted and deleted in the joining regions. So the variable part, the joining part, is very unique, and therefore it's a very useful clonal marker for all B and T cell malignancies. And you can amplify this region using the biomed primers or the LymphoTrack primers. When you want to improve the sensitivity of this assay, you need to design ASO primers that are unique primers for every joining region, so for every leukemia clone. And we do that in the past by sequencing so you have here the monoclonal peak of leukemia, and then you have to sequence that by Sanger. We did that in the past, and before that you have to purify these clonal bands, most times by page purification, and then you do the Sanger sequencing, and then you compare this sequence in an IMGT database to annotate the V, D, and J segments, and in between you have your N insertions. Your ASO primers are then designed over these VD junctions so that you get really specific primers that only can amplify this region. And you use these most of the time we use more than 2 primers, and you use these primers then in a real-time PCR assay for which you need a diagnostic material of You dilute that to a standard curve, and then you can apply this ASO-PCR to quantitate your MRD. This assay is very good. It is because it's a stable matrix, it's DNA. The sensitivity is 10⁻⁵, but you need preferentially 2 good ASO primers to prevent false negativity when the VG rearrangements when they're going to evolve during time. It's very time consuming because you have to make an ASO for every patient, and it lasts at least 2 to 4 weeks before you have this ASO-PCR running in your lab. But then whenever you have this ASO, then the turnaround time of your follow-up sample can be very short. It's just a PCR, so it's about 1 day to 1 week. This assay is very well standardized via the EuroMRD network, and it's applicable in ALL in more than 95% of the patients. But for myeloma, it's only applicable in about 60 to 70% because in myeloma you have somatic hypermutations in these genes that hamper the sequencing and also the applicability of the ASO. So that's why we started to see if we could do all these Sanger sequencing, clonality assessment, if we could replace that by NGS. The basis is a multiplex PCR on the DNA for most of the time bone marrow samples. So we started to use the LymphoTrack assay because it's an easy workflow. The basis is the same as for the clonality assay. For the capillary electrophoresis, you start with a multiplex PCR for different loci, like the heavy chain, the light chain kappa, T-cell receptor gamma, and T-cell receptor beta. And then you purify your amplicons, you make your library, and then you run this library, in our case, on a MySeq. And these FASTQ files which come out are then analyzed by software of the LymphoTrack assay. And that looks like this. So you get an Excel sheet out of it with on top the sequences that are the most frequent, the top rank here. And you can also visualize that in different ways. For instance, here you see a clonal situation, so all the sequences are the same. And here you see a polyclonal situation in which sequences are different. So it's like the capillary electrophoresis. But beside this software, we also use the Vigil software because the LymphoTrack software doesn't give us the D segments. And the LymphoTrack software, the Vigil software is developed by Mathieu and Michael from Lille. They are a bioinformatic team, and the software works very nice. You get nice visualizations of the size of the clone, and you can also compare samples. So for instance, this is the diagnostic sample, and this is the relapse sample. And when clones are the same, they are combined via a line. So it's very user-friendly. It gives you the alignments of the D segments, and which we need to produce the ASO primers. You can compare samples. It also gives you a nice report. And moreover, it gives you longer J segments, which are essential for us for producing the ASO-PCR, because we need to know which J it is. For instance, the LymphoTrack says it's a V gamma 1.2 or V gamma 2.3, while we have to know if it's a V gamma 2.3 because our reverse primers are specific for this J region. So we did some initial testing, and then we started to implement this NGS in our lab by, we tested several months in parallel, the fragment and the NGS. And what we did is that we just looked at the number of clonal fragments that we saw on the gene scan, and we compared that with the frequency of with the number of clones that came out of the LymphoTrack. And you can have a situation with 2 big clones and 1 small one, and this is also reflected in the percentage of the LymphoTrack assay. We did that for several kits. So here you see the framework 1 and the kappa, the gamma, and the beta. and most of the samples, they were concordant. We had one extra fragment, extra sequence in the NGS assay, and that was because the peak that was on the capillary electrophoresis were in fact there were in fact two sequences, so which you could not decipher by the electrophoresis, but which you could decipher by the sequence. The kappas, they were all concordant, the fragments, for the gamma also, and for the beta we had two discordant sequences. One was positive by fragment but was negative by NGS. And this was because the NGS in fact failed. We had too low reads in this case. The number of reads was too low. And in the other one, the NGS gave us really a nice clonal sequence, more than 60%, which we could not detect by the capillary electrophoresis. And when we produced an ASO against this sequence, this ASO was not able to detect the leukemic clone in the diagnostic material. So that was really a false positive one, and we have to decipher out how that could happen. We still need to work on that. For the target identification, so Sanger versus NGS, we sequenced a lot of fragments by Sanger, and they were all the same by NGS, so in B, ALL, T, ALL, and also in myeloma. We had additionally, via NGS, we could additionally sequence 20 more clonotypes, and that is most of the time due to Sanger failure if you have high background or you have biclonal rearrangements that can hamper the sequencing by Sanger, but that is not a problem for NGS. For the TLLs, we could identify 2 more by NGS, and we had 1 TLL which had no clonal marker at all, but that can happen in the very early TLLs that you don't have a rearrangement. And for myelomas, we were able to sequence 2 additional sequences by NGS, also because of the higher background, Sanger failure in fact. And we had 1 sample that was not clonal at all, in which we could not find a clonotype, but that is probably because we don't know the percentage of plasma cells. It was a sample from outside, so we're not sure that there were enough clonal cells in that sample. So we in fact were convinced that NGS works well, and so we skipped the fragment analysis. And what was when we wanted to design ASO-primers for in the myeloma situation, so we had a research project on that, so we wanted to do the MRD analysis via ASO. We still had a failure of ASO design in 5 patients of the 14. So the applicability of the ASO PCR is indeed only 64% in our hands, while via the NGS we could identify in fact all the clonotypes in all the myeloma patients. So if we could use this NGS assay also for MRD analysis, then the applicability would be in theory 100%. So we wanted to use NGS for MRD. So we want to skip all this ASO-PCR techniques by NGS. NGS can, so it's the same situation. You have to amplify the follow-up sample in the same way as you do the diagnostic sample. And then you have to sequence very deep. And then you look in your Excel file, in fact, for the clonotype that you have detected in your diagnostic sample. So the workup is the same as at diagnosis. So that means that the turnaround time of your follow-up sample is also the same as diagnosis, and that can take 1 to 2 weeks. If it depends on how many runs you will do, while the turnaround time of an ASO prime is shorter. But on the other hand, when you do the NGS MRD, you target all the immunoglobulin sequences, while when you do the ASO-PCR, you only target 2 of them, mostly only 1 to 2 of these sequences. The sensitivity would be the same. For the ASO-PCR, it's 10 minus 5. For the NGS, they claim 10 minus 5, even 10 minus 6. So we're going to test that. First thing that we did was a dilution experiment of an ALL sample in normal control DNA. And the input was 500 nanograms, and we asked for 300,000 reads. And then you see that the dilution fragments, the dilution curves start from 10 minus 2 to 10 minus 5. And it was really very linear, but all the measured points are above the expected points. And that is because you measure something else in the NGS. The MRD which we are used to speak about are in fact the number of leukemic cells divided by the total number of cells. But what you here measure is the frequency, and the frequency is in fact the number of clonal reads divided by the total number of reads. And the total number of reads are just the cells that have a rearrangement. So the frequency is dependent on the background of the B cells. And to get the same number figure as the classical MRD, we need a calibrator. And the calibrator we started to work with plasmids, but that didn't work so well. So then we decided to order G blocks. These are double-stranded linear nucleic acids which are sequence verified. And we produced 3 sets, one for the IGH, one for the gamma, and one for the kappa. And we just took 3 different regions from 3 different ALL patients. We ordered them, and we started to test several copies to see which worked best. And for us, the 10 copies each worked fine for MRD analysis. And we use now 10 copies each in 1 microliter, so we add the DNA together with the G block in our PCR reaction. And then you can count the calibrated sequences that come out in your NGS test, and you can count a calibrator correction factor. This calibrated sequence is also useful to check for contamination, so every time that we do a run, we also check if the negative control contains these calibrated sequences. And this calibrator correction factor is a simple mathematical calculation. So you know how many copies you put in your NGS, and you see how many reads come out. So the number of copies divided by the number of reads is your calibration correction factor. And then you can count your MRD. The MRD is the number of the leukemic reads that come out. You have to multiply that with this correction factor, and then you divide that by the total number of cells you have put in your PCR. And the total number of cells you can calculate from your concentration measurements, but it's more correct to use an albumin PCR, which we also use for ASO-PCR. That really gives you the actual number of cells that you can amplify. So this was already published by Fayem and Gawat in 2012. They used plasmids for this. So in doing this, we recalculated our dilution curve, and then you see that the line really comes on top of your points, and the correlation is very good. So we were really surprised that it worked so well until 10^-5. Now we started to use this assay to compare the NGS with our ASO-PCR historical data in a cohort of ALL patients, both heavy and T-cell receptor gamma low C we used. And you see already, this is the ASO-PCR and this is the NGS. And you see already that the correlation was not so bad when you compare that with the correlations described in the literature. But when you then only look at the part that is really quantitative in the ASO-PCR setting, so above 10^-5, the correlation was really good. We had some discrepancies, We had here 2 negative ASO PCRs that were positive by NGS, and this is really in the range of the lowest sensitivity of the ASO. There's probably the ASOs were not that sensitive, and we have 6 samples that were positive by ASO, which were negative by NGS, and these were positive non-quantifiable, so they're here. They're positive non-quantifiable. That means that they are below the quantitative range of your ASO PCR, so really low positive. And probably, we're not sure, but probably this has to do with the specificity. This was already described by Kotrova, which published that next generation sequences indicates false positive MRD results. And we looked in these sequences of this follow-up sample. So here you have your leukemic sequence, and this was the ASO primer we designed over the joining region. And this here is just one of the sequences we detected in the follow-up sample. And you can imagine that this ASO primer can hybridize with this complementary region in the 3xN part. So probably you can have false positive amplifications in this case. So we did that also for a cohort of myeloma patients. And we had 8 patients for which we had ASO PCR ready, 25 samples. And here we have also a really nice, good correlation in the quantitative range. We had 6 positive non-quantifiable samples by ASO, which we could quantitate by NGS. They were very low. And we had 2 negative ASO primers, which were positive by NGS. And you see indeed that they are below the sensitivity of the ASO PCR. So this looked very good. Also because we were not able to design so many ASOs in the myeloma situation. Now something about the sensitivity. Sensitivity of 10⁻⁵ means that you need at least 100,000 cells to reach that sensitivity. So you have to put in 600 nanograms, since one cell has 6 micrograms of DNA. And you would at least have to do that 3 times to be confident that your sample is negative. But if you want to reach a sensitivity of 10⁻⁶, you need at least 6 micrograms, so that's really a lot. And that means that you test 100,000 cells, and also in this case, if you really want to be sure that you're negative below 10⁻⁶, then you have to do that at least 3 times. In our routine daily practice, our DNA extractions have concentrations between 2 and 200 nanograms. So increasing the DNA input is not so feasible unless you concentrate your DNA. And that we started to do. We wanted to see if it's possible to increase the amount of DNA to 2 micrograms. We did that for one sample that was MRD positive. And we compared the MRD before and after the concentration to see if we would have some inhibition or not. So we put in 600 nanograms of DNA. The total number of cells is then 100,000. So your theoretical sensitivity is 10⁻⁵, and our MRD was 10⁻⁴. After the concentration, we put in 2 micrograms in one library. So the total number of cells is 3.3 times 10⁻⁵, and our theoretical sensitivity would be 3 times 10⁻⁶. And our MRD was, again, 1.4 times 10⁻⁴. So these are really the same numbers in PCR world, in the PCR world. So no inhibition. So it was feasible to concentrate this DNA. And then we pushed the system a little bit further, say, well, if 2 micrograms works, maybe 7 micrograms works as well. So we concentrated our DNA to 7 micrograms, and we put that just in one PCR reaction. That was really challenging, but we did that. And we made a concentration dilution curve of 10⁻⁴ until 10⁻⁶. And we tested this in an MRD setting, and we asked for 1 million reads. So you have to sequence very deep. And the results are shown here. So this is the theoretical MRD, and this is the logarithmic NGS MRD. And when you then make a nice diagram, you see that the correlation is really, really good. I was really surprised that we just could do this. So it's feasible to put in 7 micrograms in one PCR reaction. But this comes, of course, with a cost. I have put here some overall costs from preparing the library and the sequencing. So for the diagnostic sample, this is reasonable. You don't need many reads to sequence your clonotype. The library prep for, if you want to test 3 loci, it's about 50 euros, and your sequencing cost it's really low if your flow cell optimal. So you have to combine several genes and patients in one flow cell. If you want to go to 10⁻⁵, you need at least 600 nanograms and 3 times. So the number of reads is going up. The library prep is the same, because if you test 1 loci, and the sequencing cost goes up until 100 euros. So it's reasonable to do, and you can batch 20 samples in one run. And then if you want to go to 10⁻⁶, you see the micrograms. You need 6 million reads at least. I think Invivoscribe recommends even more. And that means that so the library prep is not going up if you can put this 7 micrograms in one PCR, but the sequencing cost is going up to 1,000 euros, and you can batch only 2 samples in one run. So that's really heavy for a routine lab. And we have several problems. So this is only a 1 lab experience. So if you want to implement this NGS MRD in all the MRD labs we are now, so within EuroMRD, we need to decide several issues. There are some bioinformatic issues. We have to decide how many reads we really need, how many disease reads we really need. We use now G-blocks as a reference, as a calibrator. We have to get guidelines for that as well, and we need to know how many micrograms we have to put in, how many replicates we have to do, how many PCR cycles, and also what we have to do about contamination issues, etc., barcode contaminations, etc. So we have to really standardize this technique. But in conclusion, I think the NGS has really a better performance above the Clonality capillary electrophoresis assay, because it's much quicker also to come to your clonotype, and it's very easy to interpret. The LymphoTrack assay is easy to use and highly reproducible, and the NGS MRD correlates very well with the QASO-PCR above the 10⁻⁵. The G-blocks are useful calibrators at 10 copies, and the sensitivity of the NGS MRD can be very high if you put in enough DNA. In myeloma, it's especially useful because the ASO-PCR is less applicable due to somatic hypermutation. But the golden standard in ALL is still the ASO-PCR because of the shorter TAT and because it's so well standardized. The NGS MRD has better specificity and sensitivity and gives you an additional information about immunoglobulin and T-cell receptor repertoire, but it's not yet internationally standardized. And I would want to let you know that you should always be critical about MRD negativity. If you read this, you should always see if it's defined in that sample, because it should be defined for each sample what the sensitivity is and not in a global statement. And then I have to thank a lot of people. So in the lab of molecular hematology, especially Jona van der Straat, who is here, who did all this NGS work. The Myeloma Center, from which we have the myeloma samples, and the BSPHO group, all the pediatric university hospitals that sent the ALL samples. Thank you.